First of all, I would like to thank Dr. Yakov for the kind invitation to participate in this very interesting case roundtable. So I'm going to present, actually it's two cases of mitral valve PVL closure, but they have some common anatomical characteristics that created some difficulties during the procedure and were managed in two different ways. So the first case is a 68-year-old male who had a vast medical history of combined aortic and mitral mechanical valve replacement 6 years ago due to severe aortic stenosis and mitral regurgitation. He also suffers from paroxysmal atrial fibrillation, hypertension, CKD, and he's coming now due to symptoms of general fatigue, new onset orthopnea, and impaired functional status. So initially, the transthoracic echo revealed a well-preserved LV ejection fraction, and however, a severe paravalvular leak, which was further investigated with transesophageal echo. And as you can see, it confirmed the existence of this severe PVL located in the anterior lateral position, as you can see on the left side of the screen. It was measured about 9 by 5 millimeters. The second case is about a 76-year-old male who was referred due to severe hemolytic anemia this time and impaired functional status. He had a prosthetic mitral valve implanted back in 2008. He also has a pacemaker implanted, suffers from permanent atrial fibrillation, CKD, and his blood tests confirmed that he has a severe hemolytic anemia. Also, at this point, he has on TOE, there is a severe PVL located in the posterior lateral location at this time. I don't know if you can see here. It's quite big enough, as you can see. So, what's the common characteristic of these two cases? You can see the two cases next to each other, and in both cases, despite the lateral position of the PVL, which could be in favor of easy access and crossing, however, the orientation of the PVL jet is perpendicular to the mitral valve flow, or you can call it very horizontal in both cases. So the procedural planning is concerns what is the proper access site, considering this parallel or perpendicular to the valve flow course of the jet, and what is the optimal sealing device. So starting from the first case, we did initially the transeptal puncture, as you can see on the left side, and the PVL was crossed with a Terumo wire over a multi-purpose 5 French long diagnostic catheter through an Agilis steerable catheter. The wire was then exchanged for a super stiff Ampitheatre wire, and the Ocultec PLDW rectangular device was initially chosen and advanced across the defect. However, as you can see at this point, on the 3D and the 2D image, the device is deployed but not released yet. There is an obstruction of one of the two discs. As you can see, the one of the two discs is not moving at all. So this is probably happened due to squeezing of the device across the defect, and as expected, we did not release the device. We recaptured it and retrieved it back, and we chose another device, the Ampitheatre vascular plug 3, which was deployed at this time, as you can see here. There is no interference with the prosthetic valve. And we finally released it with a very mild residual leak. So at this case, we managed to deal with the case with implanting a different device type. Going to the second case, again, we did the transeptal puncture using a flex cath sheath, a steerable sheath. You can see it in the left atrium on the right side, just positioned above the defect. And we tried to cross the defect with multiple catheters and multiple wires. The Terumo wire was not working at all. So we managed to cross the defect with Judkins right catheter, Because of this horizontal orientation of the jet, it was the only catheter that managed to help us cross the wire. And we managed to do it with a coronary wire, not a Terumo wire. However, after crossing the defect, multiple attempts were made to advance the catheter in the left ventricle, and was not able to manage it because of the lack of support and the orientation of the jet. So what to do next? Somebody can think to change the steerable catheter for something different, to use a second support wire, coronary probably wire again. Now I would definitely add the Teoman-Kilic technique, or to stop and try an alternative approach. So we decided for the last one, and a few days later we came back with the help of a surgeon, and we performed a transapical approach. As you can see, this time it was much easier to cross the defect with Terumo wire over a multipurpose catheter, advance it in the left atrium. You can see here on the 3D images the catheter through the defect, some nice pictures. The next step was to advance a superstiff wire in the left atrium and exchange it with for a guide multipurpose catheter, which gave us the opportunity to advance two superstiff wires in the left atrium because of the large dimensions of the defect. We expect to use two devices, and here you can see the first device, a vascular plug 3, 14 by 5 millimeters advanced across the defect over here, not released yet. You can see on the pictures the one device and the wire next to it. There is still a residual leak, so indeed we are going to use a second device. And over the second wire, the second superstiff wire, we advanced as the second vascular plug 3 device, a bit smaller this time, 12 by 5. So here on the right side you can see the two devices deployed next to each other but not released yet. We have to confirm that we have a good result, and as you can see on the right side on the TOE echo, the two devices next to each other deployed with no residual regurgitation, and when we are happy with that result, we release subsequently the two devices with a good final result. So in the second case, we managed to deal with it with an alternative access site. So in conclusion, the mitral valve transcatheter PVL closure definitely has a variety of technical challenges that somebody could face. The orientation of the jet seems to be one of that. The operator should be able to recognize any prosthetic valve malfunction, and different device sizes and types should be available in order to deal with these unexpected complications. And also, somebody should be able to use and utilize all the available techniques for access if needed. Thank you.
So excellent cases, Dr. Kalogeras. So George, you have any comments on that?
How often is the use of transapical approach in this area?
Not often. Very, very rare. And as we heard before from Professor Kilic, who has a very big experience, I think he never used it. Maybe for medial leaks, somebody could think about it, or the posterior lateral, which are also difficult, like the second one. So probably we could have used his technique, but it's quite rare.
Yeah, but
the other thing I would like to comment is now if somebody has a device, ASD or a PFO device, it's sometimes, or there has been another procedure in the past, then it might be very difficult to cross the septum. It's another situation.
And in the first case, so you were successful with AVP3 instead of the Ocultec device. Yes. Do you think it's the shape of that it was not big because it's?
I think it's the orientation of the tunnel of the PVL. Yeah. It may be squeezed. It was the Ocultec W, which has a larger waist in the middle, the connection wire. So it might be the squeezing of this part that interfered with the valve.
Yeah. So when you were dealing with this kind of situation, maybe you need to be familiar with both devices.
Both devices be available.
Okay, good. So
That's
that's
the
a
most
good.
difficult, I think.
George Bobas has a burning question.
First of all, congratulations, and I would like to ask, do you think 3D printing in terms of pre-procedural planning in this kind of cases where you have a mitral valve which can be seen easily in the CT scan, maybe do you think that it might have had an impact in terms of selecting the correct device or orientation in order to be faster, more efficient?
Yes, maybe it could be helpful. I don't know if it's very small anatomies and tunnels. You are an expert at this field. And the other thing, I don't know if you can predict with a 3D printing exactly how the device will orient across the tunnel.
So, George, since you are an expert, so if you do a 3D printing, you rely on CT, right?
Exactly.
In mitral.
We use the CT. The CT information that we gather is really, really amazing, and you really can predict.
Even in mitral. So,
it's even in mitral.
Because we just recently have a case that we did the 3D printing, and something that's evident in the TOE, and it was spotted by Dr. Athanassopoulos. So it was not there with the CT. So there are some discrepancies, right? Some caveats.
But if in this case you had the mitral valve, which was metal, and the origins of the metal is really, really clean in the CT, and the origins of the tissue is really clean as well, and some small holes it can be seen. I have done this kind of analysis in the past, and I don't know. I just asking if it could be possible.
Yeah. So if you're dealing with semi-rigid, which is not metal, ring.
Even it's kind of harder than tissue, so it can be seen easily through the
We can ask your help in the next case.
Exactly. So the next time we'll ask Bob.
Just ask.
So Adonis, you have a question?
I don't have a question, just to mention it sometimes when you position the device in the defect and you see that everything works fine. When you release it, you change the orientation, and sometimes that makes the problem. This is an issue that we have to be always aware and must be ready to manage. And the other thing is that, unfortunately, we don't have a dedicated device. This is a limitation of the PVL occlusion at the moment. Excellent presentation.
Good. So thank you, Adonis. So thank you, Dr.